that the number of eggs reduces, and then the quality of the eggs that you get at an older age is a lot poorer. Okay. That is why it's more difficult to get pregnant. And if you do get pregnant, most of the time, those pregnancies end up, as a miscarriage or an abortion for that matter. It is assumed that she's the one who has a problem. But unfortunately, let me tell the men who are here with us, hello, gentlemen, hello, about 40% of the cases of infertility, or rather of the causes of infertility, are actually related to men. So we are the bigger cause of infertility. Women account for about 35% of the causes of infertility. And then men and women account for about 25-30%. And then there is a small percentage where we actually sort of can't put our fingers on what the real reason is. So it is a myth that women are affected more with infertility. It's men who are affected more.
Hello good people, Susie Ledadem, living positively regardless. Doesn't matter the point at which you are in life, but we rock positivity all the way. Thank you so much, my people, for keeping it here at Susie Yule Diadem. To the new subscribers, welcome, welcome, welcome. Those who have been with us all through the journey, as usual, mbarikiwe sana, and we continue to grow together. And so guys, I want to introduce to you the guest of the day. And I hope you will enjoy, and not only enjoying, but also learning, and learning. So take your notebook and let us all learn together. Hello, Daktari.
Hi, Susan.
Good afternoon.
To you.
Good to meet you.
Good to meet you too.
And thank you for creating time for us.
You're welcome. It's always a pleasure to talk to you.
Yes.
Yes.
So, Daktari, I want to give you opportunity to look at the camera, say hi to our guys, let them know who is in the house.
Yes. Hello, guys. Good afternoon, or is it good morning, wherever you are. My name is Dr. Kireki Omanwa, and I'm your guest for today. I have the privilege of having been invited by Susan to this presentation. I am a consultant obstetrician and gynecologist. I am a fertility specialist. I teach at the University of Nairobi, Department of Obstetrics and Gynecology. I'm a senior lecturer in that department. And also I'm the president of the Kenyan Obstetrical and Gynaecological Society. Thank you very much.
Thank you. And welcome again to Susie Ledada. So guys, I always tell you, we have to get the best. And today you can agree with me that we are having the best in the house. And Daktari, here in this place, we talk of living positively regardless of the situations that are surrounding us. And one of the situations that we have worked with and we are holding positivity about it is the issue of infertility. Correct. Because I have a group of people who are following me, and some of them are going through infertility. Myself, I've gone through it, and we have agreed that surely this is an area that can cause one to keep crying, but we have decided to embrace positivity. But in that breath still, we also want knowledge. We want to learn and get to understand some of these things that looks like they're not so clear to us. And that's why we feel so privileged that we have you here on the set. And because I will just pick it from your introduction, from where you have said you come from. So I want to understand what KOG is it about.
When you talk about KOGs, KOGs is KOGS, not COGS. That is the Kenyan Obstetrical and Gynaecological Society. This is the umbrella body of all the gynecologists and obstetricians in this country. Sometimes we may not understand what is obstetrics because most of the time ladies refer to us as gynos, but not obstetricians. Obstetrics basically is the art of medicine, of taking care of mothers who are expectant right from the time they get pregnant until delivery. And then, of course, 6 weeks afterwards, whereby gynecology is taking care of all the other problems of women when they are not pregnant. Okay. So we talk about infertility, we talk about fibroids, we talk about endometriosis. We're coming to the end of March, and March has been the World Endometriosis Awareness Month. We talk about menopause. We talk about cancers of the reproductive system of women. So anything that is not pregnancy is gynecology. So we normally have these two specialties together, obstetrics and gynecology. Okay. Yes.
Does this include now the one who has a title of a fertility specialist?
Correct. Now, in order for someone to become a fertility specialist, first of all, you need to go to medical school for 5 or 6 years. And then after medical school, you need to do your internship, which is a year, where one rotates in the different specialties, that is internal medicine, pediatrics, surgery, obstetrics and gynecology, as well as anesthesiology. And then now, after that, you are now a doctor. You can now practice on your own. You have a license to practice on your own. And after working for 2 to 3 years, that is when now you can go back to specialize. And the specialization, now we are talking about obstetrics and gynecology, usually takes 4 years in Kenya, but in other countries it may take slightly longer. And after you have finished your specialization, you are an obstetrician and gynecologist. You need to work again for 2 years before you get your certificate or license now to practice as a consultant. And then after that, you can go back for another 1.5 to 2 years to study now, whether you want to be a fertility specialist, for example, whether you want to be a subspecialist in what we call gynecology, who deal with all the cancers which affect the reproductive system in women and so on. Okay. So after becoming a specialist, you need to go back again for another 2 years or so. And then now you become a subspecialist in, for example, in my case, of infertility. Okay. So it takes a bit of time.
And now when it comes to us as your clients or patients, rather, are there cases that, I know maybe somewhere we will touch on maybe some of the cases that you handle infertility, but even before we get there, are there some cases that maybe I don't just need to visit a gyna, this one I need to visit a fertility specialist?
Yes. Normally, after we finish what we call the specialization, and one is an obstetrician and gynecologist, you have a general knowledge of all the aspects of gynecology, meaning you know a little bit about infertility, a bit about oncology, a bit about general gynecology and so on. So most of the time, because we don't have enough specialists, fertility specialists, and I don't think there's any country which has enough specialists in that area. So most of the patients will first of all see general obstetricians and gynecologists. These are the ones who are many. And then when these guys most of the time cannot be able to handle these cases, they now send them to us. For example, you have been given some tablets and you're not, you're not getting pregnant. You've tried to get pregnant for a few months or even a few years, and you've been seeing your gynecologist, and then your gynecologist says, you know what, let me send you now to somebody who is specialized in this area, who now can take up this issue and try and help you.
Okay.
Yes.
Good. In Kenya, would you, doctor, say we really have a problem with infertility?
Oh yes, we do have a problem, and it's a big problem. And it's not only in Kenya, it's actually generally worldwide. Only that in the so-called developed world, in as much as, yes, the problem is there, it is slightly smaller than in our countries, which is a paradox because we have the highest fertility rates, which is about 4.1 babies per every woman. That is statistically. You can never have a 0.1 baby or half a baby. But that's just statistics. And then we also have the highest infertility rates. For example, some studies which were done some time ago put the infertility rate at about between 15 and 20% of the Kenyan population has an issue with either primary, what we call primary, or even secondary infertility. Just to sort of give you an idea, because when we say 20%, you may not sort of have an idea about the numbers. If we work with a population of about 15 million, let's say the Kenyan population about 50 million, and we say that half of the 50 million, that is 25 million, these are the young ones, primary school children, and the older women, mature women who are yet to start, getting pregnant or have stopped getting pregnant. So we are left with 25 million. Okay? So 10% of 25 million would be about 2.5 million. So if you do 20% of that, that would be about 5 million, give or take. So if you take the county of Nairobi has about 4 million people. So we would need to throw in another county, let's say maybe Machakos or maybe Kiambu, so that everybody who is in those counties, Nairobi, a bit of Kiambu and a bit of Machakos together, will make the number of people, Kenyans, who are experiencing infertility. So it's a huge problem. The only thing is that we don't want to talk about it. And because we feel that it is a problem which I want to keep to myself. I don't want to share with anybody. And then there is stigma which comes with infertility, in that when I start talking about infertility, people will look at me, it's like, what's wrong with you? Why can't you get pregnant? Why can't you impregnate your wife, for example, or your partner? I mean, we know how it is done, so why are you not doing it? That kind of thing. So people are sort of afraid to talk about it, and they think that this is something which people should... Remember COVID? Remember COVID? During COVID? We had an everyday, was it daily? It was a daily, we are being told today X number of people were tested for COVID and they were positive. Now we have about 300 and something, whatever, out of, the whole population of Kenya. But we don't do that about infertility. Whereas you see, the numbers of the cases of Kenyans who have infertility are a lot higher than the number of cases which we had of COVID.
Wow.
Yeah. Wow.
Big, eh?
Very big.
Wow. Compared to men,
yes,
are women more affected or men more affected with fertility?
Society thinks that women actually are more affected, but that is not the case. It is not the case because for women, you are the ones who show what work has been going on behind closed doors, because it's a manifestation, okay? Somebody told me that when you see a woman pregnant, you see this is the work of the scene that has been going on behind. It doesn't have to be seen.
It cannot be other way.
No, but if you are married, what scene is there? I mean, hii kazi sinafanyika. Na inajulikana kwamba inafanyika. So we sort of feel like you don't want to talk about it because everybody knows that I've been doing this thing behind, because now everybody sees that pregnancy. So when that doesn't happen, when this woman doesn't start, the abdomen it doesn't start getting bigger, 6 months, after getting pregnant, after getting married and so on, it is assumed that she's the one who has a problem. But unfortunately, let me tell the men who are here with us, hello, gentlemen, hello, about 40% of the cases of infertility, or rather of the causes of infertility, are actually related to men. So we are the bigger cause of infertility. Women account for about 35% of the causes of infertility. And then men and women account for about 25-30%. And then there is a small percentage where we actually sort of can't put our fingers on what the real reason is. So it is a myth that women are affected more with infertility. It's men who are affected more. Yes.
Wow. I think it was very important for you to mention that, because I think
do you want me to repeat it?
We'll just add the volume on that part, because it has been I think it's a myth that we grew with.
It is a myth. It is a big myth. And then the other myth that, which I think we should get rid of just straight away, is that the fact that I can ejaculate, it means I'm okay. It is not true.
Okay.
It is not true. The fact that a man can ejaculate does not mean that he is fertile. Because sometimes you ejaculate, but whatever comes out is just fluid, what we call seminal fluid, but there is no sperm, or there are no sperms in that. So ejaculation is not equivalent to fertility, because there is this method of contraception, permanent method of contraception, which men use, even though in Kenya it's a very small percentage, about maybe 1%, even less than 1%, whereby we cut what is called vasectomy. We cut what is called the vas deferens. And the vas is where the sperm pass through. So when we cut it, it means that no sperm will pass through. But these men have a normal sex life. They have intercourse, they have orgasm, they ejaculate. But what comes out does not have sperm.
Okay.
Yeah. So we have to be careful. We say ejaculation is not equivalent to fertility. No.
Oh.
Those are two different things.
Is that a good way of doing a family planning? Would encourage in a family?
Well, because it's a permanent method of family planning, then you have to be very careful. Because life, and I have seen quite a number of cases whereby in the past, this lady, or there is a couple, they have these 3 children or 4 children, and they say, that's it. And then something happens. For example, they have a divorce, and they go their own ways. And the lady gets another man and feels like, wow, I need to have a baby with this lady. I mean, with this man. And we had cut the tubes, because even in women, we can actually cut the tubes, what is called bilateral tubal ligation. And then, of course, she wants to have a baby, but she can't have a baby naturally. Or the man himself wants to have a baby with another partner, and he can't, because the tubes were cut. So that becomes a bit of a challenge. But if that is what a couple has decided, well, they really have to think about it very carefully, because reversing it is a bit of a challenge, quite a big challenge. Theoretically, it can be done, but the practicality of it is a bit of a challenge. And then once you try to reverse it and it doesn't work, the only resort is to go back to IVF, and then we do what is called surgical sperm retrieval for the men, and then for the women, of course, we can retrieve the eggs and create the embryos and then transfer them into the woman.
Okay. Oh, wow. Daktari, I know, not that I know, probably you correct me.
Go ahead. Hey, maybe you know. I know.
I wanted to imagine that you are a believer.
Yes.
And being a believer, there is this controversy that is, I know that we have mentioned IVF already. Let's just get into it.
Yes.
And there's the feeling of we should allow God to do his work.
Yes.
When we are trying to, quote unquote, make babies in the labs, it's kind of, we are now going out of the way. What is your feeling about the same?
First of all, we have to acknowledge and appreciate that all knowledge comes from God. The knowledge that we have, whether it is medical, whether it is science, whether it is mechanical engineering, or whatever it is, all this knowledge comes from a source, and that source is God. And God has given us this source to be able to make our lives better, number one. Number two, to be able to help others who actually need this help. Now, coming to the issue of creating babies in the lab, as it were, the first IVF baby was born in 1978, July 15th, 1978, Louis Brown, in Oldham, a place called Oldham, it's near Birmingham, I think, in the UK, 1978. And it created a big controversy. How is it possible that now man is going to create babies? Remember, the mother of this baby had been infertile and had been trying for X number of years. I can't remember whether it was 7 or 8 years. And scientists in the lab had actually started thinking, how can we help couples who have a challenge with infertility? They started with animals. Actually, the whole issue of IVF is basically mirrors what is done in animals. And even the techniques of IVF actually were first done in the lab with animals. Even now, we just the same process is done in animals is what we do in human beings. Now, coming back to the question of IVF and creating babies in the lab, I think anything new, when there is a breakthrough in science, the first time there is always a challenge. The same thing happened in 1967, I think 66, 67, when the first human being had a heart transplant in South Africa. And people were up in arms because the Bible says do not touch the heart, because the Bible says that the human heart, that is the seat of feelings and everything, and also the seat of other things, because he says the human heart is what? Is utterly deceptive. So don't touch it. Don't touch it. And here scientists have gone and they have touched it. They have not only touched it, they have actually removed it and put somebody else's heart there. And they were up in arms and they fought about it. And they said, we can't do this. You should not do this because you are going against God's will. But look at where we are today. We are doing several thousand heart transplants in the world. And this has helped millions of patients who have benefited from that science, which was pioneered by the great surgeon in South Africa. And it is being done even here in Kenya. So the same thing, what Edward and Steptoe did in 1978 by pioneering this method of helping couples who have challenges in getting pregnant naturally. And millions of babies have been born, through this method. So I think, in my view, it is important to recognize that, yes, this knowledge is there. This knowledge comes from God. God is one who has given us the brains, and he has given us the ability to think in abstract and otherwise to be able to help human beings, for that matter. Yes.
Wow, beautiful. Guys, it's you to make a choice, but I honestly think it is so clear. If a heart transplant is done and we are already saving lives for that, why can't we save the heart of a family who are really looking for a child? And sometimes I feel like some of these oppositions will come from people who have not experienced the pain.
I didn't want to say that, but thank you for Thank you for saying it. Because these are people who don't have children, or who may not have, who do not experience the pressure that comes from society. And this pressure comes from your in-laws, for example. If it were you who is having a challenge, when you go for family gatherings, wanasema kuna watu wengine hata walikuja tu hapa kula chakula tu na hakuna kitu wanafanya, that sort of thing. Watu wengine wamejaza tu nafasi hapa, hakuna kitu, insinuating negative things about you because you don't have a baby. I have several examples, actually. One example is of a patient of mine who for quite some time they tried to have a baby and they couldn't have a baby, and and she came and we did IVF and she got pregnant. And guess what? She got pregnant. She never told anybody. She never told the mother. She never told the mother-in-law. The only person who knew she was pregnant was the husband. That's it. To me, it was impossible, because you know how women are. Once you get pregnant, you want to share the good news. Oh, I got this. Oh, and then when you start the vomiting and the things that naturally come with the pregnancy, you want to share it with everybody and say, you know what, I've been having this problem. She never shared anything with anybody. Wow. She kept quiet. And I was asking her, what is happening? She said, I haven't told anybody because I don't want to tell. And then she would dress, she got started dressing, in very large, loose clothes. So nobody would ever suspect that she was pregnant. When she told her mother that she was pregnant, her own mother, when she was, I think, 35 weeks.
Wow.
2 weeks, 3 weeks to deliver is when she told her mother. And the mother was like, why didn't you tell me? Well, I don't know what had happened between them. And the mother-in-law, I think she had been married for about 5-6 years. And because the mother-in-law saw, you know what she did? She removed her phone number. So she had no contact with the daughter-in-law. So she had actually cancelled her. So fast forward, she gets pregnant. Quiet, she doesn't tell anybody. She delivers I do a cesarean section on her, deliver a beautiful baby girl. And of course, the husband is happy because now the mother has been delivered. She comes from, I think,
from my side,
from your side, where you know,
remember all the parents and all that.
And guess what? The day the mother-in-law heard that she has delivered, she came all the way to hospital, and she came and stayed with her in the hospital for 3-4 days, staying there. You know, I would go into that ward and I would look. The mother-in-law is seated there, and the patient is seated here. You know, there is that, you can see there's no chemistry. Ni kama kuna mishale hivi. Yeah, but you see, anyway, she had come, and then of course the baby is named after her, so she was all happy and excited and so on. Immediately, this lady was restored and she was put at a different level. Now she became
She's worthy to be called a wife now.
Now she's worthy. She's a human being. She's a woman now. She has value in society. And when the mother-in-law went back home, every week, she would send a large parcel of bananas, guache, whatever. Take them to my mother. Take them to myself. Take them to my baby because it's me. Akule chakula awe na maziwa ya kufanya ya kunilisha. You know, that sort of thing. And the lady told me, look at this my mother-in-law. All these years that I've been struggling, what she did, she cancelled me. She removed my number from her phone book. She never even called me. But look at all of a sudden now the involvement that is there. And look at now how my status has actually changed. And I usually tell my patients, I tell them, especially with the first one, I tell them, you know what? Your life has changed completely. And your status in society. Because now she's called Mama so-and-so. Yeah. Even my wife, my mother does not call her name. No, she doesn't. Even my sister said, how is Mama Mogaka? Because my son is called Mogaka. How is Mama Mogaka? Is Mama Mogaka fine? They said, yeah, Mama Mogaka. And if it's my daughter is called Shishi, so Shishi has her friends, and of course the mothers of these my daughter's friends, they also call her now Mama Shishi. They don't call her name, no. And even me, I'm not called my name. I'm also called Baba. So it is in society that you must have a baby, you must have babies in order for them to recognize you in a certain way. Yeah. And there are some certain places where you can't go and talk. No. True. Adiona mtoto? Aiya. Unaambiwa sasa wazee wanaongea. Sasa wazee. You know, even in church they say what? A bishop has to do what? A bishop has to be married and has to have his family, you know, in order. Put in order. In order. So here the family is the wife, of course, and the children. So if you don't have children, you may not be a bishop. Yeah. As per the Bible. Now, this puts a lot of pressure on everybody. I've had patients who cry and say, they don't even go for family meetings. They don't. Yeah. Because when they go there, their aunties keep on asking, so, tutakuja kunywa uji siku gani? And whatever. I had another case whereby, a very sad case, which I think we as human beings, we as Christians, sometimes we go overboard. This friend of mine in church, so there is another lady who come and, you know, poke her abdomen. Utaanza kutapika lini? Utaanza kutapika lini? Kwani tumbo haina mtoto? And then one day she did that. What she didn't know, that this lady she was poking had actually miscarried, I think a week before. Say, utaanza kutapika lini? Tunataka hii tumbo ibebe mtoto, you know, that sort of thing. But you see, of course, you can't go telling everybody that, you know what, I miscarried the other day, whatever it is. So you leave that place, that church, very, very hard. Yeah. And they're very inconsiderate. Sometimes we are very, very inconsiderate, even in church. Wow. Yeah.
Now, Daktari, here in Kenya, I think it has been made even harder from my own observation. I want to hear from your observation by the fact that seeking infertility treatment, it's quite high.
Yes.
So not only are you fighting with the stigma, and you know, sometimes we as women, you want, because of course now, even if we are saying that even this thing affect men,
Yes.
it kind of comes so automatic. You feel the fear. Like I had the other lady, we are doing the interview, and immediately they were told, now it's 2 years, you're not getting pregnant. What she thought is to rush to the hospital. But the husband never thought, I also want to go and be checked. So what we want to do as women sometimes is, I want even actually to go through the process, even without involving my husband, just in case, so that I can know my status. But now the cost of this.
Yes.
How do you?
I think that is quite a challenge. Remember, in the Constitution, in I think it's Article 43 of the Constitution, it says that all Kenyans have a right to health care. And then it goes further and says, to the highest quality of health care, and including, I think it's including, or especially, I think it's including reproductive health. All right? So infertility is part of reproductive health. And here, this is where we want the highest quality of reproductive health. Do we have it? I don't think we have it. And when you talk about the highest quality, it's not only the quality, but also there are what you call 3 A's. There is it has to be accessible, it has to be available, and it has to be affordable as well. How many of these are there? I would say none of them. Because as you've intimated, the issue of cost is quite a challenge. First of all, of course, the issue of diagnosis. You say you've been married for a year, 2 years. First of all, we define primary infertility because there are 2 types of infertility. There is primary infertility and secondary infertility. When you talk about primary infertility, this is a situation whereby there is a couple in a relationship. The World Health Organization does not explicitly say what kind of relationship, and you are in this, a couple is in this relationship, and they have intercourse 2 to 3 times a week, and a year has passed, and there is no pregnancy. That is primary. Secondary infertility is the same. The only thing is that here, this couple have had a baby, or they have babies, or they've had a pregnancy before, and now they're trying to have another one, and it is not happening. And the other caveat is that this woman is not breastfeeding, because breastfeeding in itself can actually act as a method of contraception. Age is also a factor. In the first case, when you talk about primary infertility, if the woman is less than 35 years, we wait for that year. If the woman is more than 35 years, we wait for 6 months. So 6 months have passed, you're more than 35 years, you have regular intercourse, and nothing has happened, go and start finding out what the problem is. And it's good you said that most of the time, it is the women who think, maybe I'm the one who has a problem. Again, it comes from society, because society tells you women are the ones who are what? Who are infertile. Look at the Bible, for example. Look at the stories in the Bible. We have Sarah was infertile, because the Bible says she was what? Actually not infertile, but she was barren. So barren, you may know, is like a desert. Hakuna kitu kinamea, nothing, completely gone. Imeenda na maji, and it's not coming back. So Sarah was barren. Sarah was barren. And her daughter-in-law, Rachel, was barren as well. And you remember the story of Jacob and Leah, and she was supposed to get married to Rachel and whatever. And then later on, he works for 7 years, extra 7 years, 14 years. That Mzee was in love, seriously in love. I don't know, the Kenyan men are that romantic.
Tell them to wait for a year and they will be gone.
Asema ala, kwani hakuna hii soko iko namna gani?
Ni project gani tunafanya hapa?
14 years. So anyway, he gets married to Rachel, the love of his life. And then they try again. Try. So now Rachel, which is a normal reaction, because Rachel sees her sister, Leah, has children. And he says, give me children, give me. And you know how women how you put pressure on men? Mimi nataka mtoto. Until Jacob is like, goodness, woman, I'm not God. Am I God to give you women? Yeah, I mean to give you a baby? So she gets pregnant. In the meantime, she tells Jacob, chukua huyu maid wangu, lala na yeye, na watoto wanakuwa ni wangu. And that is what happened. Okay? But eventually she does get pregnant, delivers Joseph, and delivers Benjamin later on, and she dies during childbirth, most probably because of PPH, excessive bleeding. Most probably. Because the Bible says she died during childbirth. And the PPH is what is killing our women. Susan, PPH is killing our women.
Rachel, come for your diagnosis.
Any women. PPH niliwa Rachel.
Okay.
Niliwa Rachel. And then while she's dying, she says, this child that I'm delivering, you know, what name are we going to give? He said, call him Ben-Omi. The pain, a child of my pain. And Jacob anasema hapana, hii sio jina nzuri kuita mtoto. Because it will traumatize him. Let's change the name to what? To Benjamin. Okay? So now, Isaac gets married. What happens? He gets married to Rachel. Gets married at Rebecca. 40. Is Rebecca, yeah. Yes. Gets married at 40. Look at what it says in the Bible. And they stay for how many years? The Bible says when they get married, Isaac is 40. They stay for 20 years. When the twins are born, Jacob and Esau, Isaac is 60. 20 years of infertility. And then there are so many other cases of infertility as well. So infertility is not a new problem. It has been there from time immemorial. So this is a problem which we have to approach from a sort of holistic, you know, we have to have a holistic view. So 2 years, umesema, what is happening? The ladies are the ones usually who take that responsibility. Pengine makosa iko kwangu. So they're the ones who come here. And sometimes actually when they sit where you're seated there, and they say, do we involve mzee? Nimwandikie aende kupima mbeko. Anasema hapana, wacha tumalizane na mimi kwanza. Tumalize na mimi, alafu ndio tulete mzee. So again, there's this cultural things that men are never infertile. Tunasemaga kwamba mbele iko sawa, mbele haikuagi sawa. There are challenges huko mbele. So it is a good thing for couples to come together for the diagnosis. You were talking about the cost, and the cost actually, if you look at when you talk about highest quality of reproductive health, the way we look at it is that the woman in Nairobi, and actually even in Nairobi, there are inequalities as well, because the woman who lives, let's say, in Kileleshwa, who lives in, let's say, Lavington, lives in Karen, in Runda, and so on, will have access to all the types of diagnostic tools, medications, healthcare, etc. Compare this woman to a woman in Hola, for example, in Moyale, kule juu kabisa, in Wajir, or even very, very down south in Migori, you know, or whatever. Or even in Nairobi, there are places where these women will not get that type of quality of care, where it is affordable, it's available, and it's accessible. So there are huge inequalities in this country, and I think that is a very big problem.
Okay. In your capacity, because I know this video is going to every other person who may be able to help, what do you think could be done to help in such cases? I think, and especially when it comes to diagnosis, because we even don't know what our problem is actually.
I think a lot can be done. And we are doing a lot as a society. As I said, I'm the president of the Kenyan Obstetrical and Gynaecological Society. A lot is being done. Number one, we are educating, even just by sitting here and talking about it. And this information is going to go out to the public. This is what we call public awareness. We're actually doing advocacy about infertility. Our members are very well trained in that 4 or 5 years where they do the master's degree in obstetric and gynecology. They also learn about the basic tests that can be done for infertility, where you listen to their story, the medical history, surgical history, obstetric history. Then you can actually even start some of these tests. Look at the tubes, whether they're okay, do a blood test, and so on and so forth. So there is that basic training that our colleagues have. And when they get the results, and of course, that is beyond them, they refer these patients to us now, who are specialists. So there is something that we are doing, advocacy, there is a training, there is a continuous medical education, which we are doing as a society, at the national level and also at the branch level. We are also trying to see whether we can start what is called a fellowship in infertility, or a fellowship in what we call reproductive endocrinology and infertility. This is the 1.5, 2 years training that I talked about right at the beginning, for people who now want to take a deep dive into treatment of infertility. We are trying to do that. We have a curriculum already. So the other issue is basically, where do these trainees have hands-on training when they're learning about infertility? I hope that shortly we will have an IVF center in Kenyatta. It's a project my colleagues have been following up for the last couple of years or so. But government machinery takes quite some time before things work. So these are some of the things that we are doing. And then apart from that, what we're also doing is that sometimes we do camps of infertility, where we go somewhere and say, look, we get in touch with our friends, with our colleagues in the counties, and say, from this day to this day, some of us will come and sit and go through the patients, try and diagnose the patients who are there, and see what their problems are, and see how we can help them. Is this a lot that we are doing? I think we can do a lot more. The government can also do a lot more. For example, now that we used to have NHIF, but now we have, SHA, SHIF, and I think this could be part of what SHA should be paying for in terms of diagnosis and in terms of treatment as well. The treatment, depending on what it is, if it's a small problem, we can rectify it, and these couples do get pregnant naturally. But then sometimes, if the problems are bigger, for example, they have blocked tubes, for example, they have low sperm counts, or they have no sperm at all. Sometimes they have, all manner of medical issues. These ones have to be sorted out first before we can come to the treatment of infertility. So I think the government could be a little bit more involved in terms of this. And also, remember, we also have the private sector, and we have the private medical insurance, which normally does not cater for the treatment of infertility. I think they can also come on board and also, try and help these couples who have a challenge with infertility.
Okay. Maybe, are you able to help us understand why this? Because for me, I would say discrimination. Why is it that infertility is not, most of insurance companies are avoiding it? What is the catch about?
You see, you're quiet, and I'm also trying to answer.
Because even if someone is diagnosed with a kind of a disease, we're even doing harabes there to support people. Correct. But I'm here to see harabes being done to help someone go for IVF.
Yes, because as I told you, it's a stigma. Imagine putting whatever they're saying, you know what? I cannot impregnate my wife. Kwa hivyo nisaidie ni kuchanga pesa. What some guys will say, unataka tukusaidie boss, tukuonyeshe. Obviously, no man wants to be told that. So no man will come up and say, you know what? I'm infertile and I need help. Men don't do that. I mean, not only in infertility, but generally, men don't look for help. Tuko hivyo. We are wired that way. I think my observation is that we think that if I go out to Paul and say, you know what, Paul, kimeumana boss, nataka tu nisaidie hapa, I've been quarreling with my wife. My wife comes and says, you can't handle your wife. Why are you telling me this one? That sort of thing. As opposed to women. Women, you will meet, and by the way, God created you in a very interesting way. The way your brains are wired are just out of this world. I look at you, I envy you in a way, but I can't, no. I can't do that. Because they come and meet outside at the reception here. They meet, they start, oh, hi, what's your name? My name is so-and-so. Oh, how long have you? I've been coming, I've seen so-and-so. By the way, if you need help in this and this, go and see so-and-so. My friend told me, or my sister, and went there, and they got, so first of all, there is that, you start bonding straight away by sharing, by opening up. Oh, I've been having very heavy periods. Mine, you don't even know. Me, I use Maxi. One pad, one bag. In 2 days, and sometimes I even use a towel, whatever. Just the fact that you're sharing the problem, half of it is sorted. When you live there, you actually feel lighter. And then you go further. You even take each other's phone numbers, whatever, and you even create a WhatsApp group straight away for sharing issues. Oh, wale walikuwa kwa Dr. Kireki, wako hivi, sijui nini. Wait, how did it go? That sort of thing. Men, forget it. Can't work. No way. Sisi, we will discuss about Arsenal, we will discuss about Chelsea, those ones who are for Chelsea. Yona mashemeji jana, how they play, that sort of thing. We talk about bigger issues, quote unquote, bigger issues. We talk about the war in Ukraine. You are lucky you changed it. You see how I post, like, you talk bigger issues than the women. Bigger issues, serious issues, international issues. Lakini ati hii ligi ya nyumbani, hiyo tunaanzia kina mama. We don't do that. Men can never share. Personal things we don't share. Why? Because we think that by sharing, by opening up, we are going to be perceived as being weak. No man wants to be seen as being weak. No man. No. So we are afraid of being vulnerable. And because you women, you don't have an issue with that. Completely, you have no issue. You cry with each other, you shout with each other, or shout at each other, and later on, and then after that, you're still friends. You still go out. My wife shocks me, said, I'm going for a cup of tea with my girlfriends. And she stays there, and they said, we are going out today. Guys, we have agreed with my girlfriends, we'll be away for the night. And then ask her, so how was it? We sat, we talked, we danced, whatever. We went to bed at 2:00 in the morning, whatever. I said, but what were you doing? We're just talking. Men. Hao ndio wale atakuwa amebeba mizinga ndio itawekwa mezani. You know what? And so on. So we have that challenge. So helping men becomes more difficult than helping women. Women are more open, men are closed. And the men, when I tell them, you have a challenge here, what happens is that first of all, they close up. They first of all, they didn't expect that they are the ones who have a problem. And now that the problem has been identified, they just, and they go into denial. I have a case whereby a couple got married and after a year, it was no baby, 2 years, no baby, 3 years, 4 years. And the lady decided, no, something is a problem. So there's something wrong somewhere. Having regular periods and whatever. So she goes and has herself checked. She's fine. The tubes are fine. Her ovaries are fine. Whatever, her hormone levels are also okay. So she tells the husband, now let's go and have yourself checked. First of all, it took a bit of time to convince him. Normal. And the guy goes and has himself checked. And guess what? He doesn't have any sperm. What you call azoospermia, zero sperm. So in the history that the gentleman had surgery in what you call a hernia. There's a small opening on the side of the abdomen called the inguinal. And so he had both sides. He had what you call a bilateral inguinal hernia. And I think while they were repairing the hernia, they must have cut or tied the tubes inadvertently. So the guy did not have any sperm. So we tried to find out. I've said most probably it's because of that surgery. You know what happened? The guy went into denial. he went into a block. So, okay, you have a problem, yes, I understand, but we can still do IVF. We can still do what is called surgical sperm retrieval, and we can create embryos and we can transfer them into this lady. Nope. The lady could not get across to the man completely.
Wow.
She threatened, she cried, she threw tantrums, she did everything, and the guy was like a wall. Nothing. So she reached a place and decided, you know what, since I'm not able to talk to this man, I can't get across to him, why don't we adopt? The guy said, fine, adopt. You know, it's like, it's your problem, it's not my problem. So they adopted a baby girl, I think, if I remember well. And then after some time, they adopted a baby boy. And now the lady sort of, you know what, I have drawn a line in my life. See, I have children. And she continued. She forgot about any other interventions. 14 years later. How many? 14 years later. The guy wakes up one day and says, by the way, we can do IVF. And the woman was like, what did you say? I said, yeah, I think we can do IVF. 14 years after the diagnosis is when the guy came to terms.
Wow.
With the diagnosis and say, now we can do IVF, I'm ready. And the woman is like, really? 14 years? You know, me, I've forgotten this story. Me, I don't want this thing. But then she said, because again of, asikuje kusema kwamba mimi ndio nilikata. Let me just do what? Let me just go ahead and do it. Remember, her age had now gone what? The age is, I think she was 38 or maybe 39, where the chances now have really dropped. As opposed to where she was 14 years earlier. She was around 24, 25 years, where she was, you know, right at the peak of when she could have these babies. Of course, unfortunately, it didn't work. But just to show you, you know, some of the extreme cases that can, So men, we have a problem. We really do have a problem.
Okay.
Yes.
Dr. I'll go into that now. We have already discussed about some of the things that causes infertility. You've already mentioned quite a number in the discussions. And maybe I still want to understand more. Are there such maybe kind of like maybe our lifestyle or what are the most common things that you think we do ignorantly but they can cause us the issue of infertility?
Age, for example. I mentioned age right at the beginning. The woman's age is a big, and I want to underline here and write it in capital letters and in red, that age is a factor and a big factor, especially for women. Why? Because women are born with a set number of eggs. And these eggs reduce every month you have a period. So if you start your periods at 12, 13 years, by the time you get to 35, 36, 37 years, you've had periods for 23, 24, 25 years. And it is approximated that every time you have a period, you lose about between 800 to 1,000 eggs. It's an approximation. It could be more, it could be less. But even if, let's just work for the sake of discussion, and let's say you lose about 1,000 eggs out of 500,000 that you started with. So if you lose 1,000 eggs every month, in 12 months you'll have lost 12,000 times 25 years. Let's say you started your periods at 12 and you are now 37. So 12,000 a year times 25 years. I don't know how much that is, but it's a huge number. So number which has been lost. And remember, a woman is fertile once a month. So that good egg will come once a month. These other ones, ni zile zinaharibika. So you can say you are losing a lot. But I think men are at a worse position. We lose millions of sperms.
But do they get depleted? Here, even at old age, a man will
but God, it's unfair, but that is the way it is. Nothing is fair in this world. Because for men, every 2.5 months to 3 months, tunatengeneza store. Tunatengeneza. And as opposed to women, you guys start with a fixed number.
It goes reducing.
That is why if you get a man who is let's say 70, 65, whatever it is, na anaweza kusimama at attention, ile bunduki asimamishe hivi,
nivo
anaweza kushoot na akishoot vizuri, inashika. But you, it's the other way around.
Okay.
Once you get to 40, it doesn't matter. It's going to be a tall order. Now, mkifika 45, 50, forget it. It doesn't matter.
Okay.
Forget it. You'll never, most probably you'll not get a baby.
Okay.
Yeah. Wow. Again, because of that, the number of eggs reduces, and then the quality of the eggs that you get at an older age is a lot poorer. Okay. That is why it's more difficult to get pregnant. And if you do get pregnant, most of the time, those pregnancies end up, as a miscarriage or an abortion for that matter. And if they managed to sort of circumvent the natural mechanisms that the body has of getting rid of anything that is not normal, anything that is abnormal, you find the majority of these babies have a problem, chromosomal problems. Down syndrome, for example, which is very, very common. The older we become, again, because of the reasons that I've explained.
Okay. Wow.
So age is a factor. So wale ambao wanafanya kazi wanasoma, wasema mzee amenipeleka shule, soma kabisa, by the time you finish and whatever, while you are in school, some of your classmates can be hitting on you. Unamwangalia unasema hata kiatu hii, I think this one is hitting on me. And then, you sort of don't look at this guy. This guy will go to another school, go to the law school or nursing or whatever, and get a lady from there, get married, starts the normal struggles of life. After kidogo, amepata mtoto, whatever. They start now the real social life. Meanwhile, you as a lady, you are focused. Masomo.
Very focused.
Na unasoma kabisa, unapata degree moja, degree mbili, unafanya hivi. Then you come out, now you start rising up in the corporate world. And corporate world is very, very demanding. You don't have a social life per se. And the guys who are hitting on you, now they have 1 or 2 babies, whatever. Wherever you're focused on getting that life. Now, by the time you get to the top of the corporate ladder, umepata pesa, masomo iko, and you have that red Mercedes Benz that you've always dreamed about. And unakaploti mahali, where you build your whatever house, alafu unaangalia hivi unapata ala. There is no man and there is no baby. And then you start wondering what happened to you. Now your mother starts asking, sasa mtoto wangu, sasa nitakufa bila kuona mjukuu, Now pressure starts coming from you. Not only the pressure is coming from your mom and whatever, it's also coming from yourself. Because now you look at your age mates, they are settled, they have a family, and you talk about different things. You are talking about going on holiday to Diani, to whatever. Then they are talking about little John and Mary, how they have not been sleeping, they are teething and whatever. So you're in 2 different worlds. Kabisa. Now, the ones who have a child or children together, they will actually, because they have common issues, they'll be talking about their issues. Wewe unakuja, even if you're very close in college or whatever it is, you're an outsider. They don't invite you for birthday parties because you don't have a child who will run around with these other ones. Hey, John, kababa, sijui nini. You don't have that, but they have that. And then women, again, I think it's a protective mechanism, self-preservation mechanism. They will not call you. Kwa maana nafikiria wewe ukija, maybe you start hitting on their men again. So you are ostracized. Sasa unabakia na corporate nini yako na pesa yako. Some of the social things that we do, of course, we forget about, again, there are some other causes. For example, women have polycystic ovarian syndromes, you have endometriosis, we have fibroids, 30 to 60% of women of African origin, doesn't matter where they are, have fibroids in the reproductive period. And of course, there are other issues, hormonal imbalance. You have a very small percentage may not have a womb, and so on. And then there is something which is disconcerting because, again, we've reached a place where we say, whatever a man does, a woman will do what?
Better.
Will do better. Sasa ile ulevi ambayo yuko Nairobi. Because unasema what a man does, a woman can do better. Sometimes when I look at a drunk man, I'm not being, sort of patriarchal. It's sort of acceptable, even in society, to a certain extent. The most disgusting thing is to see a woman who cannot put a sentence together because she's completely high. Amelewa hata hajui mahali yuko. What happens is that, whether it's a man or a woman, when you are drunk in such a state, you don't know whom you're going to pick or who will pick you. And when you wake up, where you're going to be. And then, unashindwa, unaamka asubuhi unashindwa, first of all, where am I? And then you look at this man next to you and say, what is this next to me? Niko wapi? When did I pick this man? Or when did this man pick me? You know? And then you don't know what has happened in the night. And then unashtukia kidogo kidogo, oh, you are HIV positive, kidogo kidogo, you know, you have issues, you know, you have sexually transmitted infections, you have herpes, chlamydia. Chlamydia is one of the biggest problems. And most of the women that I see, actually I would say about 80 to 85%, have a problem with their tubes. Their tubes are blocked or their tubes are stuck and they can't get pregnant because of that. Why? Because of the social things that we do. Tunakunywa pombe, tunavuta sigara, shisha squeezy, even though it is banned, but I can guarantee you, ukienda some of these places, you'll see smoke it, you know, whatever. And God forbid that you start also taking some hard drugs and so on. That is one of the biggest, another problem. The other thing is, you see, once you get married, your mother, you know, hey, you are taking good care of your husband. By what? By feeding him properly. Sindio? Yeah. So kijana ambaye alikuwa kama pola hapa kijiti hivi, after a few months, unaona ameanza start. Why? Because the wife is taking good care of him. Sindio? Yeah. Na wewe pia, you go somewhere, the ladies will ask you, kwani is your husband locking the fridge for you? Why are you not putting on weight? So you start putting on weight, which is a good thing. I think our African men love their women to be, you know, which is that word I want to use. They have to have somewhere to hold. Let me put it that way. Now, it becomes a challenge whereby when you put on a bit of weight or you put on weight, na mzee naye pia he's also doing okay. I mean, naye yuko na public opinion. So when it comes to having sex, it becomes a challenge. Sasa hapa kuna kitambi na mama pia naye amekula vizuri. You know, it's like having sex and you have you have a pillow in front of you. So you mzee atafika wapi? Mzee hawezi kufika. And then you also get frustrated. This man is not doing what he's supposed to do. And then now the bedroom, you know, sports become a challenge. And then when you start thinking about that, those bedroom sports, say, hata mimi sitaki, you know what? And so remember the definition we had about having intercourse 2 to 3 times a week. It comes to maybe once a week, kwa sababu tumechoka. Or then it becomes maybe once every 2 weeks. Sometimes it comes once a month, once a quarter. And I have patients who come and say, you know what? I can't remember the last time we had sex. How long have you been married for? Oh, we've been married for about 10 years. And you can't remember? And you say, no, I can't remember. So hii chakula unapata mahali pengine. He says, Daktari, let me not answer that question.
It's an answer by itself now.
So I keep quiet. Sit out. So these are some of the things that we do. I had a patient who came and told me, when you ask, one of the questions that we ask is whether they smoke. No, they drink alcohol. Yes, we drink. They said, oh, okay. How much? What do you drink? I drink a bottle. I thought it's a bottle of wine. But even a bottle of wine is a lot of alcohol. Anyway. So I asked, so which, you said you drink a bottle. He said, a bottle of what? He said, a bottle, Mzinga. Oh, Mzinga. Okay. Mzinga is it a liter or 750 ml? Something like that, of alcohol, of Johnny Walker. Actually, she mentioned Johnny Walker. I said, okay. So in my mind, I'm thinking, well, if you have a Johnny Walker of a month, 2 months, you come and take a tot, you know, whatever it is. I don't drink. But I imagine that is what they will do. Social. That's what I taught here, just to quote unquote make you feel happy, you know. She said no. I said over what period of time? He said over every Saturday evening. I said, excuse me. At what? I said, yeah. Every Saturday evening, anangusha mzinga. Every Saturday evening. I can afford it, so I buy. So how are you going to get pregnant like that? How? You can't.
Okay.
And then apart from that, that liver imechomeka. So after some time, she'll have what is called liver cirrhosis, scarring of the liver, and the liver will stop working. Once the liver stops working, you have kidney failure, and it's a domino effect. Please, you have to stop and watch kunywa pombe.
Okay.
She said she will stop. She stopped coming to see me instead. She stopped coming. So these are some of the challenges. For the men, of course, we have issues like lack of sperms, azoospermia. Where you have maybe the tubes were chopped or whatever, they were cut during surgery or whatever it is. But sometimes they may have the testicles inside the abdomen, not in the scrotum. Okay. So they will be producing testosterone, which is, makes us men. We have that deep voice and we have a beard and so on and so forth. But then they will not be doing the primary function of actually helping in the development of the development and maturity of sperm. So you find, Awana, there is no sperm. You find that sometimes some of the men have what is called retrograde ejaculation, meaning instead of the sperm coming out, it goes back. It goes back into the bladder. We can help them. Because once we've realized that it's retrograde ejaculation, they can actually have intercourse. And when they have an orgasm, they finish, we tell them go and urinate. We put that urine in a container. We will actually pick those sperms from that urine and we'll use them. The others who have, I think the biggest problem for men is basically sperm. The different issues with sperm. Either the volume is too low, the number of sperms is low, the total number, what you call the count, is also low. You have the quality, the number of those ones which are good is also very low, and so on and so forth. So everything revolves around the sperm and the production. So you may have hormonal imbalance. This hormonal imbalance will affect the sperms. You may have injuries. Sorts of injuries. We like contact games, football, cricket, hockey, rugby, and so on, where sometimes we really get into this, and they may get hurt, in the region, in the reproductive region. So these have consequences later on. Sometimes the testicles may twist around on themselves, either on one side or both sides, and then we have to remove that, because if we don't, this person will end up having serious infection, generalized infection, sepsis, and so on. So you can actually remove that. All types of cancers. You may have cancer of the testicles, for example, that can be contributory to that. Accidents. And we see all this manner of accidents. You have a car accident and maybe you're injured in the reproductive area, or you have an accident and you are whatever is also injured. So you don't have that reflex of getting an erection. We have an issue with erectile dysfunction. And this comes most of the time with age. And then we have issues with diabetes, issues with hypertension, because these directly affect the vessels which supply blood, to the scrotum and to the testicles, for that matter. And then we also have the blue pill.
Okay.
The blue pill for young people, and unfortunately, again, this is a societal problem, an ethical, moral issue, because you find mature women, I don't want to call them older women, because women are never old, women are mature. Mature women, maybe in their, I don't know, 50s, 60s, or whatever it is. They already have now, financially they're okay and whatever, but they don't have a person who will be able to rise up to the occasion as they want. So what do? They get younger men to quote unquote service them, you know. So they pay for them to go. They are called bentens. They used to be called bentens. I don't know whether that is still the case. They take them wherever, they cater for their transport, you know, and whatever and so on. The job of this young man is to do what? Kufanya service. So service physiologically 2 times, maybe 3 times in a night. Lakini sasa kwa huyu mama, because she's been lacking this thing for a long time, anataka mara 5 mara 6, you know, because she really wants to make it. And you just may not be able to get up to the occasion. So what do? Blue pill. So they start taking a blue pill. So they do that after some time. And then after some time, it stops working. What do these mature women do? They drop you. They get somebody else. A colleague of mine, a senior urologist, was saying he's seeing an epidemic of young men with erectile dysfunction. Can you imagine? You're 29, you're 30, and you can't get to attention. You cannot have an erection. And now, and you umeenda kanisani sasa vizuri, you are engaged. Munaenda honeymoon. Sasa you are whatever, sasa ndiye anajua leo hii kazi itafanyika. Nothing happens. Nothing happens. Huge disappointment. So these are some of the things that some young men get involved with, not looking at them, not knowing what the possible consequences can be. And the consequences can be really, really huge. Yeah. So this was another thing. And then there is another thing, which I think I got 1 or 2 patients whom, very interesting case, whereby he was in love with another girl. That one of, do they call it boulders and everything? And then his family said, no, you can't get married. And of course, because it is family pressure, whatever, and you don't want to be a rebel, said, okay, fine, I'll get married. They got married with this one, whom the family wanted, whatever. Nothing doing.
Wow.
Nothing doing. Nothing doing. I think when I listened to him, my thoughts were, every time he's with his wife, goes out with his wife, he would be thinking about what he was supposed to have. And there was no connection at all.
Wow.
And he said, you know, my wife is beautiful and everything, but
nothing.
So how do you have a baby with her now? And she's a young lady, by the way. So yeah, some of these things which we think that, you know, we have to follow society, we have to follow culture. Kwetu inakuwaga hivi kwamba we choose a woman for you. Meanwhile, your heart is somewhere else.
Yeah.
That sort of thing.
Guys, I'm really learning a lot. Wow. I think we are learning, apart from health-wise, we are also learning socially. How we need to adjust our social life. What wamzinga over the weekend.
Can you imagine?
Wow.
Oh, yeah.
I think we should just have a glass of water. We'll be coming back with part 2 to wrap it up with understanding the treatment available for infertility. So kindly watch out for part 2. Thank you.